Good morning, all. I don't know if you can hear me. If you can hear me, can you just wave your hands? Let me be sure. Okay, thank you very much. May I kindly request that all the facilities on the call should please turn on your video. We want to see you, as well as individuals that want to do so. Please send in your attendance and then let all other facilities that are yet to join on the call, please share the link with them and let's have them join. We'll be looking at a very interesting one today, and we have one of our renowned subject matter experts available to talk to us. Before then, I'd like to quickly call on the Federal Ministry of Health to give us an opening remark. And standing by to do that is Mrs. Lami Mayaki, a statistician at the NASCAP Division of Federal Ministry of Health. Mrs. Mayaki, please, you may want to unmute yourself and let's hear you. Mrs. Mayaki, are you there? Or Labake from the Federal Ministry of Health, can any of you go ahead and do the remark?
Oh, Prosper, good morning.
Good morning to you.
She's speaking now.
Okay. Good morning, everybody.
Good morning to you.
You are welcome to another interesting HIV healthcare services. Today, HIV Spice Echo section is dedicated to look at efficiency HIV case finding and linkage to ART. I once again appreciate the CID, USID, and with all their IPs present, as well appreciate our SME and for their great input and impact of more knowledge to boost our HIV health service in Nigeria. I especially appreciate the Vice 3 and NASCAP, particularly SI staff anchoring these weekly sections. On behalf of National Coordinator of NASCAP and leadership of Head of Strategic Information, Dr. Adebobola Bashir, I welcome you all to today's section and declare the section open. Over, Mr. Prosper.
Thank you. Thank you very much, Mrs. Mayaki, and thanks to NASCAP, as you earlier said. Now, before we go, I also would want to call on U.S. Center for Disease, U.S. CDC representative to give us a good way message. We have Victor Adamu, who is the acting branch chief of HIV prevention at CDC Nigeria. Victor, please, can we have you give a good way message from CDC?
All right, thank you very much, Prosper, and good morning, everyone. I would like to welcome you all to today's session. This didactic session proves to be very timely and apt given the times we're in. We know that we're approaching treatment saturation in a lot of our states and subpopulations. So as we continue to look for more cases, it's going to be more and more difficult to find them. Therefore, we need efficient ways and strategies to be able to identify new cases and link them to treatment. So I believe we will all learn from this session and apply such learnings accordingly. Enjoy and have a good session. Thank you, and over.
Thank you very much, Mr. Victor, for that remark. So I want to call, we have our topic today is HIV efficient case finding and linkage to ART, which is very key to management of our patients. No matter what we do, if we can't link them to care and follow up, then it will be impossible to make sense of our services. We have one of our renowned subject matter experts, Dr. Eugenia Ofondu, who is a consultant dermatologist and a GUM physician. She's currently the HIV manager at Federal Medical Center Owerri. Dr. Eugenia, please, we are glad to have you after a very long time, and you may want to share your screen and let's hear from you. Thank you very much.
Good morning, everybody. Prosper.
I can hear you. Good morning.
Okay, let me stand on existing protocols that have been established. It's a pleasure to be with you today, and I'm looking forward to a very interactive session at the end of it all. Could you share the slides from your... Hello, Prosper.
I can hear you.
Yes, can you share the slides from your side?
Okay, just give me a minute. I didn't
Yeah.
get that ready.
Okay, so like I said, it's a pleasure, everybody, to be here to discuss efficient ways.
Can you see my slide now?
Yes, we can. So can I
Okay.
go ahead?
Please go ahead.
Excellent. So we're here today to discuss efficient HIV case finding and of course the linkage to ART, without which HIV case finding cannot be complete. Next slide, please. So we hope that by the end of this session, we'll be able to have participants discuss HIV case finding, that participants should also be able to describe the recommended HIV testing algorithm in Nigeria, which I presume all of us already know, to discuss the high yield, innovative HIV testing service strategies, and then to discuss the linkage to care that wraps it all up. Next slide, please. So what is HIV case finding? Why are we trying to find HIV cases? As Victor said in his introduction, we are reaching saturation and epidemic control, and it's becoming more and more difficult to identify people living with HIV who have not yet been tested and identified. So HIV case finding is a strategy for targeting the resources we have, both human and material, at individuals or groups who are suspected to be at risk or exposed to HIV infection. It is an active process. It is not passive, whereby we're waiting for the client to come to the hospital sick. It's an active process looking for at-risk people so that we can identify them early, put them on treatment early, and reduce the likelihood of transmission. Next slide. So I'm sure we're all familiar with this particular slide. According to our Spectrum estimates, Nigeria has about 1.9 million people living with HIV. And out of this number, about 97% of them have been tested and know their status. And out of this number, about another 97% who know their status are on ART. And out of those on ART, about 96% are doing well and are virologically suppressed. So we could say that Nigeria is doing well, can't we? But let's look at the next slide. Prosper, the next slide. But about 3% of individuals are yet to be identified. And this 3% equates to about 57,000 individuals. Looking at the population of Nigeria, more than 200 million, that's like looking for needles in a haystack, difficult to find. And because they're difficult to find, they are ticking time bombs for us, in the sense that these individuals are active, going about their daily activities, their occupations, and transmitting the virus to other people. So it's not a static situation. And if we remember that every day a certain number of people pick up the virus from others, we will know that we need to work hard and fast to identify these 57,000 people in Nigeria, put them on treatment, and halt the epidemic. Next slide. So because of this, right, it is really important for us to identify the modalities we can use to find the 57,000 we are speaking to. And if you look at this slide, it clearly shows us that community HIV testing, right, is winning the race in terms of identifying individuals who have HIV. So in the year 2022, PEPFAR statistics show us that about 50% of those who were identified positive came from community-based HIV testing. About 22 to 23% came from index testing, and the other 14.9%, almost 15%, came from provider-initiated testing and counseling. Then facility voluntary testing gave us just 7.3%. All the other areas where testing was carried out gave us far smaller numbers. So this tells us at a glance where we should be focusing our efforts. In the community, doing index testing, and then, of course, targeted provider-initiated testing and counseling. Next slide, please. So what are some of the strategies for optimizing HIV case finding? Now, if we look at the orange box up top and on the left, it describes for us targeted testing. Targeted testing utilizing index testing, which could be called index partner testing or index case finding, peer testing or social network testing, and then geolocation, whereby we're able to map out areas where testing has generated more new cases for us and enables us to focus on those areas. The red down below looks at self-testing. Self-testing is targeted at certain populations, specifically the key pop made up of men who have sex with men, female sex workers, people who inject drugs, and the trans and diverse gender. It also targets children, adolescents, including both girls and boys, but especially the girls, and of course, young women and men. However, looking at all these innovative strategies we have defined, it is also important to recognize that facility-based testing can also give us a certain yield, as seen in the provider-initiated testing and counseling in the previous slide. So we must also identify the opportunities we have in the facility to maximize testing at both the inpatient department, the outpatient department, in our STI clinics, of course, in our TB patients, in the endocrine clinics, and the malnutrition clinics. This process of active HIV case finding cannot be said to be concluded unless there's active referral and tracking of the people who are identified positive to ensure that there's linkage to care and treatment initiation, and also to ensure that those who are identified negative are linked to prevention treatment programs that will ensure that they stay negative. Next slide, please. Okay, so what we have described so far in terms of innovative strategies would fit into one of the first four boxes you see. It's either we're dealing with optimization of provider-initiated testing and counseling, or we're dealing with index test, counseling and contact tracking, or we're dealing with HIV self-testing or recency testing. And these are modalities of HIV testing services that are differentiated. And invariably, all of them need to be linked to care and treatment for our HIV testing services to be stated to be complete. Next slide. So, if we all think back to when we started the journey with HIV management in Nigeria, we started off with diagnostic HIV testing, where the patients who present with symptoms or signs of HIV are tested for HIV. From there, we moved to universal coverage, whereby all patients who are presenting for medical attention, regardless of their complaints, are offered HIV testing. But we had to look at the testing efficiency, which this slide, based on PEPFAR data, tells us. And it was necessary to become a little bit more innovative in terms of testing, and then ensure that resources, scarce resources, are saved. So the risk stratification tool now came about, whereby people are tested who are at an increased risk of HIV based on their behaviors or their clinical signs and symptoms, or the demographic factors of where they're coming from or where they have been going to. Next slide, please. So these strategies for strengthening HIV case finding in the health facilities can look at universal coverage, which tests everybody who is an inpatient, who has tuberculosis, or who goes to ANC, who presents with an STI, or who is malnourished for HIV. Or screening using the risk stratification tool for those presenting as outpatients, for orphans and vulnerable children, and also adolescents, for those presenting to the Well Baby Clinic and adolescents, and of course, for those who come for voluntary counseling and testing. And then, of course, index testing, very interesting, whereby a person who is identified positive, who is the index client, has the contacts tested, be the index client a HIV positive woman, pregnant or not, a HIV positive man, or a child. So let's go to the next slide and look a little bit more critically at what provider-initiated testing and counseling requires. And there are several steps to provider-initiated testing and counseling. Now, at each step, everybody who is involved needs to be informed. But provider-initiated testing and counseling is a process whereby the HIV testing services are recommended or offered by the healthcare providers in the facilities to people who are attending the healthcare facilities. And in this process, everybody is informed about the need for HIV testing. It is an opportunity to inform people about what HIV is, how it is transmitted, and how it is prevented. So information is given to everybody. Those who are present are screened to know whether they are eligible to be tested. And those who are eligible, either because of the risk stratification tool that is applied, or because they meet criteria based on the fact that they have certain co-infections like TB or diabetes, or because they also have malnutrition, or because they have an STI, are eligible for testing and are tested. All those who are tested need to be counseled and provided their results, whether the results are positive or negative. And upon receipt of those results, they all, whether they are positive or negative, need to be linked to appropriate services. In the case of somebody who is negative, to prevention services to ensure that the person remains negative. In the case of somebody who is positive, to HIV care and treatment services for ART initiation and follow-up. So therefore, provider-initiated testing and counseling, as we can see, has 5 steps: inform all, screen all, test all, counsel all, and link all. Next slide, please. So in HIV index testing, we have the HIV positive clients. Who is the index client? This is the person who has been identified positive. And it is assumed that from this one index client, the yield of others who could be HIV positive would be high. The contacts of this individual that are important to look at would be their partners, sexual partners, both in homosexual and heterosexual or bisexual relationships. Would also be partners with whom they share needles for those who are people who inject drugs. Would also be their biological children, whether they are male or female. And if the index client is less than 19 years, their biological parents, both mother and father, not just the biological mother, as is indicated in the slide. Next slide, please. So there are 10 steps to index testing, and I'm sure you've seen this slide before. So you want to introduce the concept of index testing. You want to offer index testing as a voluntary service to all the clients who are testing HIV positive or with a high viral load. I need you to note this second step. I'll repeat it again. You want to offer index testing as a voluntary service to all clients testing HIV positive or with a high viral load. The third step, if the client accepts, you want to obtain what? Consent. And that consent has to be informed consent to enable you inquire about their partners and their biological children. Having done that, you write a list of all their partners and biological children, and also step 5, conduct an intimate partner violence risk assessment for each named partner or child. You also want to determine the preferred method for each partner for notification or child testing, bearing in mind that we usually have how many different types of notification? 4, either patient referral, provider referral, the dual referral, or the contract referral. And for us to refresh, in the patient referral, the patient accepts to go and notify the partner or partners and is given a referral form to that effect. In the provider referral, the healthcare provider is permitted by the index client to go ahead and notify contacts and goes with the referral forms himself or herself. In the dual referral, both the index client and the healthcare provider notify contacts of the index client together. And in the contract referral, the index client agrees that within a stipulated period of time, usually 2 to 4 weeks, that he would have notified his partner or her partner. And if that is not done, gives permission for the healthcare provider to go ahead and do that. So once this notification is done, contact of all the named partners and biological children takes place, and a record of the outcomes of the testing of these partners or refusal to test and the reasons why is documented. Appropriate services have to be provided for children and also for intimate partner violence. And of course, a follow-up of the client, it's himself or herself, that's the index client, needs to occur to ensure that there were no adverse events associated with index testing, especially intimate partner violence. Now, I want us to go back to step 2. It's very important because it's a step that we don't seem to be laying enough emphasis on, and that is offering index testing to those with a high viral load. So most of our index testing is focused on people who are accessing HIV care and treatment for the first time, those that are newly identified positive. And that is great. We want focus to continue on that and actually increase. But we also want us to look at our existing recipients of care who have a high viral load. We know that the higher the viral load, the easier it is for them to transmit the virus to their partners, be they in homosexual or heterosexual or bisexual relationships, and also to their children. So the same process of index testing that takes place when somebody presents newly during testing should also take place for somebody who has a high viral load. So let's have a look at the process. Next slide, please. Right. So look at our index client. You can see our index client in red. So our index client, who is HIV positive, has informed that he has 3 partners, partner 1, partner 2, and partner 3. Partner 3 is HIV negative and is immediately linked to HIV prevention services. Remember, we said that everybody who is tested needs to be linked, either to prevention services if they're negative or to care and treatment services if they are positive. Partners 1 and 2 tested positive and were immediately linked to HIV treatment and offered index testing services for their contacts. Now, our first index client in red has given us 2 new index clients, partner 1 and partner 2. Just click, Prosper. Just click on the slide. Good. So our first index client has given us 2 new index clients who are partner 1 and partner 2. And these 2 partners, immediately they are linked to HIV treatment. They will be offered index testing. And the cycle does what? Continues. Okay? And this process is not concluded until the sexual network is completed. So this cycle continues. So one index client in red has given us 2 new index clients, partner 1 and partner 2, who may eventually give us 4 or more index clients, and it continues to cascade like that. So it's an active process that continues to roll down. Next slide, please. So HIV self-testing. HIV self-testing is a process in which a person does his or her own collection and does the HIV test themselves. And this can be done either alone or with the assistance of someone he or she trusts. It is mostly done at home or in communities, but it can also be done in facilities where HIV self-test can be left in strategic points where the individual can test alone or decide to ask for assistance from a healthcare worker that he or she trusts. So there are clear-cut instructions in the literature that is within the sample for collection, performance, and of course, interpretation. But why do we do HIV self-testing? Next slide, please. The rationale for this, which will be the other slide, sorry. So A negative HIV self-test result usually means that the person is HIV negative, and the person is not encouraged to do a retest unless they have had potential exposure within the last 6 weeks, in which case they are encouraged to retest after 6 weeks, or they are repeatedly engaged in risky activity that puts them at risk for HIV, in which case they should retest again after 3 to 6 months. In the KPs, it is recommended that they retest after 3 months, okay? So, but why do we use HIV self-test? Next slide. Next slide, great. Okay, so this is looking at global statistics. So since the pandemic started, we'll note that about 84.2 million people have been infected with HIV. And out of this number, about 40.1 million have died. And we're left with about 38.4 million people living with HIV as at the end of 2021. Out of this number, 36.7 million adults, which is the first blue column that you see, who are 15 years and above, are people living with HIV, according to our Spectrum estimates. And these are global statistics. And 30% of these 36.7 million people are unaware that they have HIV. Remember, we said in Nigeria, we're looking for how many people? 57,000, okay? And then globally, about 30% of 36.7 million people are unaware that they have HIV. And that is the starting point. If we do not identify individuals, how are we going to treat them? How are we going to ensure adherence and ensure that they're virologically suppressed? How are we going to use treatment as prevention to reduce the likelihood of transmission to other individuals? However, we've noticed that there is inequity in testing, especially in men, especially in adolescents, and especially in the key population. And to close this testing gap, we have to reach these subpopulations in unique and innovative ways, because most of them don't want to come to the traditional HIV testing services, which are domiciled in where? Health facilities. Next slide, please. Okay, so recency testing itself refers to an antibody-based test. This antibody-based test distinguishes recent from long-term HIV infection using the binding strength of the antibodies or antibody avidity. This test will tell us whether somebody recently acquired HIV within the last 6 to 12 months. And it is a very useful tool to tell us where recent infections are occurring, and also enable us to gather the data of who these recent infections are occurring amongst the various subpopulations, and ask the question, why? And enable us to plan to target how we can prevent further recent infections from happening in these localities. The test should be done immediately after the clients test positive using the national algorithm. And the rationale for this is that when we identify people with new HIV infection, next slide. When we identify people with new HIV infections, it enables us start mapping out where this is happening, where the areas of high transmission are likely to be, where we need to focus our prevention programming, and where we can generate the data I spoke to about who, where, and why these recent infections are occurring. Next slide, please. Okay, so this speaks to epidemic control. Now, epidemic control is this process or the situation whereby the total number of new HIV infections is less than the number of deaths in HIV positive individuals from all causes. And that is where we want to be. Okay? Now, it's important for us to be able to detect the recent infections, because remember the definition is new HIV infections. We need to detect the recent infections. Like I said, we need to know who, where, and why we have recent infections. And then we need to be able to target prevention of these recent infections to ensure that we interrupt further transmission. And how do we do this? Just tap on it, Prosper. We do this. Yeah, so we do that by ensuring that we're able to rapidly test for recent infections. Next slide. So laboratory tests for recent infection are again antibody-based tests, which distinguish the recent from the long term. Now, they can give us both false positive and false negative results due to the immune response of the individual or due to the various subtypes of HIV-1 that can occur, or even due to the use of ARTs in the past that the client did not speak to, and of course, due to advanced HIV disease. In a bid to reduce the likelihood of these false results and improve the accuracy of interpretation, algorithms have been developed called recent infection testing algorithms, which incorporate the recent rapid test for recent infection result with other markers of chronic infection to enable us have better accuracy and reduce the likelihood of false positive recent results. And we're going to look at the algorithm that Nigeria uses now. Next slide, please. Okay, so this is the national HIV testing algorithm that includes recency infection testing. So you have your HIV positive. Let's start. You have a client who presents for HIV testing services in the white box, and he has serial testing undergone with a rapid HIV test. And if that rapid HIV test is reactive, he has the next rapid HIV test done. If that is reactive, the client immediately is tested for recent infection using a rapid test kit for recent infection. And if that rapid test kit for recent infection tests positive or tests recent, immediately viral load sample collection is done for that client. If the viral load comes back and is greater than 1,000 copies, that client is confirmed to have a recent HIV infection. Next slide, please. So having looked at these 4 major modalities for innovative or differentiated HIV testing, being enhanced provider-initiated testing and counseling. Secondly, of course, HIV self-testing, index testing, and lastly, recency testing. We must make sure that all those who are identified positive are linked to HIV care and treatment services, and that is ART linkage. ART linkage is seen as the period that begins with a HIV diagnosis and ends when the person has been initiated on antiretroviral therapy. Next slide. So it spans the period between the first 95s, the first and the second 95s, between diagnosis and treatment. So you have your first 95, those who are diagnosed HIV and know their status. The second 95, out of those who are placed on ART, and of course the third 95, those who are virologically suppressed. So therefore, ART linkage spans between the first and the second 95, next slide, and is seen as a handshake between HIV testing providers and HIV treatment providers, and is a critical link because if somebody is identified and not linked to care, it becomes difficult to stop what? Transmission in the community. Okay, next slide. So the linkage to treatment involves both the HTS providers and the ART service providers. The HTS providers would support active linkage of those who are negative to prevention services, as earlier stated, and also support active linkage of those who are positive to treatment. They would need to explain the importance of initiating HIV treatment to those who are newly identified positive, not just provide information about where and when to go for HIV treatment, but also ensure that these individuals are actively escorted to where they're going to receive treatment and enrolled into HIV treatment. So the job does not just stop at telling a newly identified HIV positive client, oh, you're positive. No. Till that client is enrolled and linked in to HIV treatment, the job of the HTS provider has not been concluded. The ART service providers on their own part need to ensure that they are able to provide same-day ART initiation, and where this is not feasible, to ensure that they have SMS appointment reminders to bring that person back to the clinic or the treatment center to ensure that the person is able to assess care and initiate ART as soon as possible, preferably within 7 days of being identified HIV positive during HIV testing services. And ensure that there's follow-up using phone calls or home visits for this individual to keep this person in care. But even when all this is done, there are still individuals who are likely not to agree to link up to treatment. And these individuals are most likely, based on previous research, to be men, younger persons between 15 to 24 years of age, those who have secondary or higher education. Next slide, Prosper. Yeah. So those who are less likely to link up to treatment, regardless of all we do, are men, younger persons 15 to 24 years of age, those who have secondary or higher education, those who are employed as against the unemployed, and the newly diagnosed as against those who have known their status for some time. These individuals are less likely to agree to link to treatment. And let's look at some of the reasons why. Next slide. Right. So there are personal, cultural, health system, and economic reasons why people find it difficult to link to care. We've talked about age. This age bracket finds it difficult. We've talked about being male. You have instances where A couple may be identified positive, and the man sends his wife to the clinic to go and pick up drugs for both of them. And even when the wife comes back with only drugs for herself, the two of them may share their drugs together because he's not ready to be linked to a facility to pick up his drugs. You have those who are afraid of the side effects of the drugs. They've heard that, oh, if you take the drugs, this will happen or that will happen. And they say they don't want. You have those who don't trust the results that were given to them, even though the test was done right before them. You have those who are afraid of disclosure or stigma and discrimination. You have those who are feeling healthy and ask, why would I need drugs? There's nothing wrong with me, nothing do me. So why are you trying to tell me to take drugs? You have those who clearly do not understand the importance of starting their treatment early, and those who believe in traditional healing, and of course, those whose perception is impaired, maybe due to substance abuse, and cannot take critical decisions for themselves. Culturally, the fear of stigma and discrimination still exists, especially amongst the key population. And with regards to the health system, some facilities are seen as unfriendly, again, because of the attitudes of you and me as healthcare providers, and at times because of self-stigmatization by the recipients of care themselves. You still have facilities that have long waiting times because people are not being devolved, and multi-month scripting of ARTs has not been maximized to ensure that the waiting times are reduced for recipients of care. You have those who were not adequately prepared during the HTS sessions in post-test counseling to understand that they need to access care fast. You have those who are working who will tell you that the times for the health systems are inconvenient for them, and they would prefer to pick up their drugs during the weekend or in the evenings. At times, these health facilities, their clinics are closed during that period. And of course, the economic, which most of us can relate to, an inability to miss work, to go and pick up drugs, okay? The high transportation costs, which seems to be increasing daily, the fact that it's a very long distance to the HIV clinic. For a lot of people like KPs, migration from one place to the other, so they are not domiciled in a particular place all the time. And lastly, but also very important now, food insecurity, where people are focused on, let me at least find food for me and my family to eat and stay alive. I do not have enough money to go to the hospital. I do not have enough time to go to the hospital. I am struggling to feed. So these are some of the barriers that come against appropriate and adequate linkage from HIV testing services for a person who has been identified positive to treatment and care. Next slide, please.
Dr. Eugenia, the time is almost up, but I'm enjoying the presentation. I didn't know how to
We
tell
have
you.
just 2 more slides, Prosper.
Okay.
So I'm going to wrap up fast. Okay. So to strengthen linkage within facilities, right? We need to look at 3 processes. And these 3 processes in the facilities are the same processes we're going to see in the communities. We have to look at the processes that people go through during testing, okay? Escorting the clients to the clinic is critical for ART linkage. We can't just point out where they're going to receive treatment and tell them to go. Some of them will slip through the gaps, okay? Ensuring that a list of all those who are referred to a facility
Dr. Eugenia, we can't hear you.
linkage coordinator is able to track all those who have been referred to the facility, in whom it wasn't possible to initiate ART the day they were brought to the facility. And of course, in terms of tracking, those who did not present to the facility, lay counselors and community health workers should ensure that they are able to track these the community. This is really important because, next slide, Prosper. In the community, hello, Prosper.
We already
Excellent.
yeah.
Good. This is the last slide. So in the community, it's really important because we have so much community ART initiation going on. So we're seeing people in the community, we're identifying those who are positive, we're starting them on ART in the communities, and then we're having difficulty bringing them back to the facilities. So you have people who have been initiated in the community and they're refusing to come to the facilities, and you don't blame them. It's very convenient to stay in your house and receive your drugs, but there are things that need to be done in the facilities. There are assessments that need to be done. There are individuals who have AHD that need what? More intense management within the facilities. And this is where the job of the community counselors and the community healthcare workers comes into place to ensure that those who have been initiated in the community are brought back to the facility using the same mechanism that was used from HIV testing services to the health facilities. Use it to employ the same mechanisms to bring people who have been initiated in the communities back to the health facilities for appropriate assessment as and when it's due. Finally, before Prosper chases me away, last slide. So our key points for this presentation: HIV case finding is a strategy for targeting resources at individuals or groups who are suspected to be at risk of contracting HIV infection. It is an active strategy. And we're using things like optimizing provider-initiated testing and counseling, index case testing, targeted community testing, HIV self-testing, and recency testing to increase our yield of those who test positive and increase the testing efficiency. HIV self-testing has been proven to close the testing gap and reach individuals who are not prepared to access our traditional HIV testing services, which are offered in health facilities. And of course, improving the linkage to antiretroviral therapy involves strategies both within the facility and also in the community, especially for those who have had ART initiation in the community. Thank you so much for listening to me. It's been a pleasure taking this session, and I hand back over to Prosper. Prosper, over to you. Thank you.
Thank you very much, Dr. Eugenia. This is awesome. Before we go to the question, I was just, I saw there was a slide that I saw where the linkage, the link between the ART and the, I can't find it. Yes, this slide. So I was saying that if this is the stress or what is involved in linking from HIV positive to HIV care treatment, many will not want to jump this long thing. I saw it, I was like, hope people will not see this as the stress involved in linkage to care, because the gap is much.
We are, Prosper, we are equal to the task.
If I jump this, I'll break my leg.
Everybody on this call, right, who has been in HIV management is fit and can do this jump even with their eyes closed. I have faith in our healthcare workers, especially those in the HIV program.
Thank you very much. Thank you very much.
You.
this presentation is so awesome. I didn't even know how to tell you your time is up, because I was enjoying the whole narrative and all the explanations. Thank you very much, Dr. Eugenia, and it's nice to have you. I hope you'll be available to be featured more often, and I believe the participants are also interested in having you, talk to us. So do we have questions? I know this is well detailed, it's quite explicit. So I don't know if we have questions. For salvation of time, we are already out of time, but we can still entertain one or two questions if there is any. Okay, so we'll have PHCC Maraba Guruku. I'm just enabling, sorry. Please, can you raise your hand again? PHC Maraba Guruku, I mistakenly lowered your hand. Can you raise it up again, please? PHC Maraba Guruku. Okay, so PHC Maraba Guruku. I can't see your hand, Maraba Guruku. PHC, can you raise your hand again? Okay. Please, can you unmute and ask your question now? PHC Maraba Guruku.
Okay. Yeah, good morning, everyone.
Good morning.
Yeah, my name is Stella from PAC Maraba Gruku, IHV and Nasarawa. Thank you, Dr. Eugene, for your wonderful presentation. Then my question is in the area of barrier to link to care. You made mention of the barrier, one of the barriers, sending the wife to collect, and the issue of PUID, people who inject drugs. And the process of you a community tester, you went to the community and you tested the patient. Then you leave the patient to the facility. Then after the counseling, on the process of registration, counseling, you identify that that patient is a PUID. Number one, can you enroll that patient in that facility, like in primary health care, or can you refer that patient to another facility? That is number one question. Two, you have some of the people that are afraid for this to disclosure. Then at the end of the day, you try to do your proper counseling. The patient will now able to make an informed decision by bringing the social contact. And it happens that one of the social contacts is not within. Maybe he's staying at Lagos. And what do you do at that junction? That are my questions. Thank you so much for your wonderful presentation.
Thank you very much. Dr. Eugenia, just for time factor, I don't know if I should take all the questions and have you use 1 minute to respond to it.
That's fine, Prosper.
Okay, so let's have IHVN, let's have IHGN River State Program. Can you unmute yourself? Please, you have 30 seconds to ask your question. IHBN River State Program, GH Degema. Can you unmute yourself quickly?
All right. Thank you so much, Dr. Eugene. We really appreciate this time you've given us this talk. I actually want to know, because we're having this challenge here of persons who are reactive, and despite all efforts to counsel and bring them to care, they have actually resisted. They are still resisting till date. And in course of doing our job, we had to move, and we see that these persons actually are becoming more promiscuous, having known their status, not minding how they go about this. And we strongly believe that they might end up infecting more people while we are trying to put a stop to a spread of infection. So to people like this, how else can we follow them up? How else can we follow them up? Can we try to cancel them? And we have actually noticed that there are some of them, you try to get their attention, you try to reach them, and they knowingly want to put you out of the line.
Thank you.
That this is what they want to discuss about. So they knowingly want to put you out of the line. So when we have people like this, we know that the populace is at risk. How then do we?
Thank you very much. Thank you very much. Can we have, I see clinical mentors training ongoing somewhere. You have questions. Can you raise your hand again so that will enable you just in 1 minute? except your concern has been addressed. So let's have, I'm not going to take all these questions. Questions are more. Can we have okay, PCH Maraba group you've been attended to. So can we have GH Kafanchan, please, in 1 minute, ask your question, GH Kafanchan. GH Kafanchan, are you there?
Yes, good morning now.
All right, good morning.
I quite appreciate the resource person for this enlightenment.
Thank you.
So my question is regarding to this enlightenment. I did not hear the time spent for a client cancel and have enrolled as a new client that come for these services. So because why I ask the question is because of the time that we are looking at, maybe whereby we are saying that this client's time is being taken. So that's why I'm asking the question.
Thank you.
What's the time? Yes, I've pressed my question for one, from testing to the time of recency and AHD-related baseline investigation to have the person enrolled. Thank you.
Thank you. So final one before, I'm just going to give us 30 seconds. Let me have IHBN River State Program, Moses. Can you quickly unmute yourself and ask? Moses, IHBN Rivers Program. Okay, Moses is gone up. So can we have Dr. Eugenia, Dr. Yetunde Akani? I saw your hand up, but I can't see it again. Okay, Dr. Yetunde, please, can you take 1 minute to respond? You said?
No, they will here to respond.
Okay, good morning, everybody on the call.
Yes,
and
please.
Special thanks to Dr. Sondu. That was a beautiful presentation. Sincerely, I am attuned to what you did this morning. And so I was actually calling to respond to that diagram that Prosper pointed out. And so you were thinking of the negative aspect of it, but then the essence of that diagram is to help you see that there's this huge gap between treatment and initiating people on treatment or after testing and then linking them up to care. And so that is the gap that we want to close. And that's why you see that Professor Osondu took her time to talk about the various strategies and what needs to be done so that we can optimize linkage to care, because testing people without linking them up to care is as useless as not even testing them. So that's exactly what that diagram is trying to. It's trying to tell you that there's this long gap, there's this huge gap that we need to close up in the course of care and treatment of persons living with HIV. So
thank you very much.
And that's just what I wanted to say. Yes.
Thank you very much. Now I know. Thank you very much, but nobody will break his or her leg. Thank you very much, Dr. Yetunde. So I wouldn't want to take more questions. Let me allow Dr. Eugenia to see if he can use one minute to respond so that we can be here on or before 11:10. Dr. Eugenia, please, over to you.
Thank you so much, Prosper. So first question was from PH Maraba, right? And
yes.
You talked about a PWID who is tested, and can you enroll the person in a primary health care center? For a PWID, there are certain services that individual needs, okay? So remember, we're talking about ensuring that people get psychosocial support, which may not be available in a PHC, especially PWIDs and other key population, okay? And then you're also talking about replacement therapy, okay, for them in a bid to see whether you can break the drug cycle. So they do need specialized services. If River State, and I presume River State has an OSS, right? Those services will be available at an OSS. And it will be important to actually not just refer, but physically escort this client to an OSS. There are also key pop-friendly health facilities. We visited Anambra State, and you will be amazed that we got to a Catholic hospital and there were key population who were comfortably accessing their care and receiving specialized services at this particular Catholic hospital. because their motto is what? No discrimination. So keep up, we're comfortable there. So it's important for PWIDs to ensure that they get the specialized services they need. I would advocate that they are referred to where they can get this, and they should be escorted to that place to make sure that they actually reach there. Now, for somebody who is afraid to disclose, right? And the person maybe has now made an informed decision. That was your second question, okay? And the individual whom the index contact is in Lagos, right? And you are in Port Harcourt. That is where our communication as healthcare providers come in. Having called this individual, with the consent of that individual, your colleague in Lagos can follow this person up. The HIV program is a national village. I won't say global, but we're a national village, okay? You have directories within facilities, with the SIPs that tell you who is doing what in each state. So it is easy, with the permission of that individual in Lagos, to link that person up with a healthcare worker that can easily access him in Lagos and get the job of testing done. But it has to be with the person. Answer those two questions. For IHVN River State, GH Degama, I'm sorry I didn't catch your name, but you brought up a very important issue. And this, I think, is an issue that River State needs to look at, because this is probably where the gaps in River State are in terms of linkage to care, with individuals who know their status and who have refused to be linked. The first thing that needs to be done is to ask why. Why do they refuse to be linked to care? Is it because the facilities that are being offered to them do not suit them? Is it because the timing that is given to them to present for care does not suit them? Is it possible to provide an innovative way of giving them treatment? And this may be something that goes beyond this general hospital. I believe it should be escalated to the SAPC for the state, and I know she's very, very vibrant, and also escalated to the IP for the state. We also have a national clinical mentor and state clinical mentors in River State, whom I hope are on this call and are taking note about this issue brought up by General Hospital Degama in River State. So we need to go into that community and find out what are their reasons why. Is this a community where community ART initiation has to take place? And if yes, in what particular manner? Who are the gatekeepers for these individuals that can be reached, okay, that could change the narrative in this particular scenario? It's not a one size fits all. That's why it's important to find out the reasons why they are refusing. There's usually a way to reach an individual. Sometimes it's appealing to the fact that they have families, and if they're not treated, even if they don't care about their wives, they care about their children. The likelihood that the children they have could be positive may just be the thing that makes somebody think twice about not accessing care. So there are so many different strategies that can be used, but first you identify why they are refusing care. The third question came from GH Kafanchan, and you stated that you did not hear the time between identification and then enrollment. We did mention that it is preferable that within 7 days, right, of ART initiation, it is desirable to do ART initiation on the same day that HIV testing is carried out. It is preferred, if that is not possible, that within 7 days, somebody who is identified to be HIV positive is enrolled into care and treatment. For those with AHD, AHD is a totally different presentation. But for somebody who has tuberculosis, as identified by TB-LAM or clinical signs and symptoms or the gene expert machine, then you would be looking at starting ART within 2 to 4 weeks of starting anti-TB medication based on the CD4 count. And I'm sure the lecture on AHD has been taken. For those who have cryptococcal meningitis, you may have to wait up to 4 weeks, okay, before you're able to start antiretroviral therapy. Again, the reason being because of IRIS, immune reconstitution inflammatory syndrome, which is likely to come up more and may actually cause mortality in such individuals. Dr. Yetunde, I really appreciate the comment you made as regards the gap between testing and linkage to care. And Prosper has already confirmed that it makes him feel better as regarding the diagram. And I hope it makes everybody else feel better too. That's the most I can say for today. Thank you once again. It's a pleasure. Prosper, over to you. Over and out.
Thank you very much, Dr. Yetunde. Dr. Eugenia, I want to beg that we'll be featuring you more on a monthly basis until we elapse the scope or the area that you are part of. And then if there are other areas that you feel that our participants need to know as HIV manager, please, we will discuss that in private so that we can feature that more, because this lecture and this session today is very engaging. I can see it even from the faces of the facilities on the call. And I personally here, it was very enriched. I feel very, it was very enriching. Thank you very much, Ma. Do we have Dr. Matthias? Dr. Matthias from CDC. I don't know if you are still on the call. Let's have a final word from CDC, or Victor Adamu, or Essien. Dr. Matthias, please, I don't know if you are still there. Can you hear me? Okay. John Essien, are you there? Okay. Can we have someone from the FMOH give a closing remark quickly? Mrs. Lami Mayaki, are you there?
Okay, yes, Labake is here. Prosper.
Okay, please, yeah, a closing
Thank
remark,
you
please.
once again. Yeah, so good morning. Can you hear me clearly?
I can hear you.
Can you hear me?
I can hear you,
okay. Yeah, thank you very much. Good morning, everyone, once again. And to Prof. Eugenia Fondu, thank you, Ma. We really appreciate you for being on the call this morning and for the excellent delivery on this all-important topic. I believe that every one of us on the call this morning have really learned a lot, and also the innovative strategies to be able to for client tracking and also linking to care. We really appreciate you this morning, Ma. It's been a pleasure having you on the call. It's been a while we've seen you on the call, so it's good to have you this morning. We really appreciate you. And also to all our healthcare workers, we thank you for your participation and for your commitment at the facility levels in ensuring quality service delivery to all our clients. We really appreciate you. And to all other SMEs in the presence of Dr. Yetunde Akane and then Dr. Chika Onwama, we thank you all for your inestimable contributions to this platform. And to CDC and to all other national clinical mentors on the call, and also to the NSHIP team of NASCAP and to NASCAP colleagues. We really appreciate you all for being on the call. To FICE 3, to CCFN, CIHP, APIN, and all other IPs that I'm unable to mention. We really appreciate you all for your support as always. And on behalf of the Federal Ministry of Health, the leadership of NASCAP, Dr. Adebobola Bashiru, I wish every one of us a wonderful Thursday. See you all next week. Bye for now. Thank you, Prosper. Over to you.
Thank you very much. And from here, I have my colleague, Dr. Naji, Dr. Azukan Naji, and the rest of the 5 stream members. We'll see you again next week. Please, the link and the presentation slide will be shared shortly. Thank you all, and do have a great day. Bye for now.